regarding the psychological process that leads to suicidality. For example, the role of hopelessness, defeat, entrapment, burdensomeness, thwarted belongingness. These are all now evident in well-researched and well-supported psychological models of suicidality. And even better, the research is moving further into areas that will have a greater clinical utility for us to understand the differences, the different psychological processes involved in those people who have suicidal ideation as opposed to those who attempt suicide. Because far more people experience suicidal ideation than those who actually attempt suicide or those who actually die by suicide. And of note here is Clonsky and May's ideation direction framework. And again, similarly, further advances in psychological research are underway, thinking about the role of conflict and control and limited awareness in development of suicidality. So, thinking about suicidality as a psychiatric symptom, well, why is it a problem? Well, I believe it's a problem because people who experience suicidality are not getting the help they need because of the prevailing domination of the idea that suicide is a part of a psychiatric diagnosis. Current services in the UK are largely defined by a diagnosis. So, for example, we have PTSD service or CBTP for psychosis. And that leads staff training and the delivery of services to be directed towards treating a particular disorder. But we also know from very strong multitude of systematic reviews and meta-analyses that generic interventions like CBT, for example, for people who are said to have psychosis, these generic interventions failed to address the particular psychological processes which are inherent in suicidality. So I've been doing some studies alongside many RCTs, talking to staff who are working with people who are suicidal, mainly in inpatient wards, and talking to patients themselves, suicidal patients. So staff, in interviews I've done with them, describe very deeply ingrained beliefs of suicidality as a symptom of a diagnosis. They refer to it, for example, there's some quotes here which I can read. One person said to me, well, it's like any other mental illness really, like voices or like, anxiety or whatever, that this, referring to suicidality, is an extreme thing, but it's symptomatic of something else, a diagnosis. And unfortunately, staff often have very little training in interacting with people who are highly distressed and suicidal, and they often feel unskilled and incompetent, lacking training and organisational support. So the fear of saying something wrong and of being culpable as blamed for somebody killing themselves, because there is unfortunately a very widespread belief even within mental health services, that if you talk about suicide, somebody's more likely to kill themselves. So one nurse said to me, you're going to have suicide risk, but you think, well, psychologists will deal with that because I'm a nurse and I don't have to deal with that. The only problem with that viewpoint is that there aren't very many psychologists working in inpatient wards. And the fear of being blamed is very, very prevalent. This was highly mentioned in all the interviews I did. One nurse again said it's scary because, at the end of the day, that's why, the documentation will come up, you'll be sacked and you'll lose your job or you'll lose your PIN number, the registration number that people in the UK have as nurses. And further details of this particular study and others are listed below. And if anybody would like any of the references, then please contact me directly. So let's think about what patients say then. Well, patients talk about lack of opportunity to talk to staff and to find ways of understanding what's happening to them. And people have said things, for example, just talking about the suicidal thoughts and why I've got them, talking about it would really help because there's no one to talk to about it. Another person said, in hospital, they just ask you, have you got them, referring to suicidal thoughts? And if you have got them, they just try to give you some medication for it. They don't talk about why you've got them. Again, staff fear of saying the wrong thing leads them to want to sort of close down conversations and not open them up, because they believe it's part of the diagnosis. So if you're treating whatever the person came in with, depression, psychosis or whatever, they believe then this will lead to a good outcome, but unfortunately it doesn't. And patients learn that it's not okay to talk about suicidality and that there'll be negative consequences if they do. For example, this might mean that they are kept in hospital longer or denied certain benefits like going out for a walk. And people have said things to me like, I've opened up to people in the past and they've used it against me. And people have said, well, if I wanted to kill myself, I wouldn't tell anybody, which is obviously not a good place to be when we know that talking about suicide can be a very protective thing to do. The diagnostic dominance in terms of thinking about suicide has been cited by O'Connor and colleagues as one of the issues that have contributed to very limited progress in reducing the suicide rates over the past 50 years, actually. Although the suicide rates have fluctuated up and down a little, but haven't really made a great deal of impact onto them, definitely within the UK, and I would also potentially argue globally. So there is suicide prevention research has been dominated on the epidemiological level, and risk factors of largely static variables have been the subject of much research. But many of these are unchangeable. You can't take away some psychiatric diagnoses, bipolar disorder being one, for example. You can't not be male anymore, and you can't revert a history of being suicidal. These are all sort of static variables which are often used to develop risk assessments, but these kind of actuarial risk assessments have actually been banned by NICE, and in their place has been sort of assessments. But they are still happening in some places, unfortunately. So the problem with the epidemiological research is that it overestimates people who don't kill themselves and underestimates people who do. It's kind of referred to as the low risk paradox, that most people who died by suicide in the UK, if they were known to mental health services, had previously been assessed as having a no or low risk of suicide. So these kind of ways of looking at things definitely don't work. So in summary, I believe that the evidence that we have available does not support the idea that suicidal thoughts and behaviours are symptoms of psychiatric diagnoses. I feel that there is a much stronger evidence demonstrating that suicidal thoughts are distinct psychological processes influenced by all kinds of various negative experiences of adversity, social disadvantage, etc. And I do also feel that the perpetuation of these contested etiological theories, for example, about deranged neurotransmitters causing psychiatric disease, which then becomes labelled by diagnosis, I believe that these are unhelpful in terms that they inhibit research and practice of the individual level intervention that can be targeted and concerning the psychological processes within suicidality. And also that the contribution of this sort of diagnostic approach brings with it the psychiatric treatments, which, as I've heard from staff and patients, largely amounts to sedating people and inhibiting their ability to talk about things. And this is something we find in the research trials we run, that sometimes people would like to try the psychological therapy, but they're actually too sedated to engage with the psychologist. So that's one sort of avenue that is then denied somebody. So in terms of recommendations, I suppose we come back to the generic thing that, you know, suicidality is but one symptom of a psychiatric disorder, and many of us are now increasingly taking issue with the idea that psychiatry has limited evidence for these diagnostic categories. So I suppose we can only fall back really on thinking about professional and public education to, you know, further advance theories regarding the societal influences, social determinants of mental health difficulties, and I suppose inherent in that demands a paradigm change from these diagnostically driven mental health systems to a more humanistic, more supportive ways of helping people understand and make sense of psychological distress. and making it understood that very often people's distress is not inherent within the individual, but is actually part of much broader systems. So that's the end of my talk. And as I mentioned earlier, if anybody would like the references to many of the things I've discussed, then please do contact me direct.
Thank you, Yvonne. I'm going to suggest that people unmute if they can, to give a warm hand to Yvonne for a wonderful talk. And despite being unwell, you turn up looking absolutely fabulous and give us a brilliant overview there. So much appreciated. And we've got a minute before Vanessa comes on to talk about some of that suicide research in a bit more detail. For any questions? No, you must have just blown everybody away.
Oh, I think, do we have one from Anne, I think?
Yeah, hi. Yeah, it's really just, I'm just kind of, thank you, brilliant talk. As I said in the chat, I'm just kind of really struck from when you summarize it, how the kind of current diagnostic paradigm leads to a kind of perfect storm of people not getting help when they need it. So you've got the, the idea that it's a symptom of illness and all we need to do is treat the illness. You've got the stratification of the different, different professions. You've got, where nurses think it's not their job, as you said. You've got the blame culture where nobody wants to be the last person who talked to somebody or to have said the wrong thing. And so they, so and it all sort of comes together just to mean that when people are at their most vulnerable, most need to talk and most need help, they don't get it. Or if they get anything, they get more meds, which they may or may not, possibly may not be more helpful. I suppose it's more an observation than a question, but it just really struck me.
Yes, thank you, and I agree completely.
And it was really helpful, Yvonne, to have some of that information that you got from interviewing staff and also, most importantly, service users. I'm just wondering whether there's, because I know you've done so much research in that area, and there wasn't time today to talk about it in depth, but was there anything else that came out of that that might support some of the recommendations that you've been making?
Well, I have spoken to staff who recognise the failings within the system, and there are lots of staff who are psychologically minded. Some of them even have qualifications in CBT therapy level things, but unfortunately the system doesn't allow them to use this. It sort of requires a big system change, really, of supporting people to be able to support patients, really, and creating those cultures where they're exposed to a broader level of information than just one sort of line of thought, really. There's a lot of stuff, I think, would like to move into much more humanistic practice, but unfortunately they're working within often quite brutal blaming cultures themselves. Yeah,
thank you. And it's all very litigious as well, isn't it? So people are scared to move out of that culture. But okay, well, thank you very much again, Yvonne. Next, we have Vanessa McIntyre, who's our PhD student based at the University of Manchester. I do know where I work, honestly. Do you want to try sharing your screen, Vanessa?
Yeah. Can you hear me, by the way, just to check?
I can certainly hear you.
Yeah, cool.
So Vanessa's going to do a 5-minute talk, so I won't hold you up, Vanessa.
Okay, can you see the slides? Yeah.
Yes, thanks.
Okay, so yeah, I'm a second-year PhD student, and I'm going to talk about how I'm using perceptual control theory to understand how people go from thinking about suicide to making an attempt. So we need more research to understand how people go from thinking about suicide to making an attempt, since, as Yvonne mentioned, only some people who think about it actually go on to try and end their lives. So we need to understand why these people do that. And understanding this progression better will help us to improve and develop psychological interventions that can prevent this progression. And so I'm using perceptual control theory since it's universal theory that's been applied in transdiagnostic mental health research with good effect with disorders such as psychosis and bipolar disorder, but hadn't yet been applied to understanding suicide. So with my PhD supervisors, I've developed a new theoretical framework for understanding suicide that's been informed by PCT, which has been published recently. And its main hypotheses are, so since PCT is focused on how control is important for people's psychological well-being, and if they experience a loss of control, often due to internal conflict between their personal goals, then people find this distressing. So one of the hypotheses is that people try to end their lives as a way of trying to regain control of their experiences. So, for example, trying to end the hopelessness or despair that they're experiencing as a result of that conflict between their goals and loss of control. And also, the main important hypothesis that I'm testing in my PhD is that people who go on to actually make a suicide attempt do this when they have limited awareness of how their other goals that would be negatively impacted on by suicide. So, for example, someone who wants to be a good parent to their children in the future, at the time that they're wanting to end their life, that goal isn't in their mind at all. They're just focused on ending the distressing experiences and regaining control. So we think this is what's happening when people have talked in anecdotal accounts about experiences of tunnel vision. So this exclusive focus on the goal of ending their life, of regaining control, ending the distressing emotions, and no awareness of these other goals that would be negatively affected. And so in my PhD, I'm planning to develop and validate a psychological tool, which would be a kind of interview for assessing this limited awareness, so people's awareness of these other goals in a suicidal population. And then use this to compare people who've thought about suicide with people who've actually made an attempt, to see if there's a difference between these two groups in terms of this limited awareness. And I've already got some preliminary data from a pilot study I collaborated on with Sara, one of her master's students. In which we interviewed students with experience of suicidal ideation and students who made a previous suicide attempt in order to examine how aware they were of these other goals. So examine their limited awareness at times when they thought about suicide and times when they made a suicide attempt. So the key findings from that qualitative study were that people believed that suicide would stop undesired internal states. So, for example, if they're experiencing thwarted belongingness, it would stop the distress from that. And also that people who made a suicide attempt didn't think about these other goals, so the consequences at the time of the attempt. Whereas people who only thought about suicide but didn't make an attempt were deterred by thoughts of potential consequences. So these other goals. And I've got some quotes from that study to illustrate this. So someone talking about how suicide would end these internal states that they didn't want to feel said, this is like the only way I'll not feel like this anymore. And then someone who made a suicide attempt talking about how they had this limited awareness, so they didn't have awareness of consequences, said, at the time I had no understanding of implications whatsoever. Whereas in contrast, someone who'd thought about suicide but not made an attempt said, I thought about my relatives and my family, and that was always the thing that stopped me. So throughout my PhD, I'm hoping to gather more data that will hopefully support these hypotheses. Thanks for listening.
Thanks, Vanessa. That was great and really succinct. So you were bang on time. Much appreciated.
Thank you.
Discussion is coming, so obviously people might want to talk about this some more. But next up, and if you can stop sharing your screen, Vanessa, I'm going to ask Louise Noronha to come up and share your screen. And it's a pleasure to introduce you, Louise. And I've been looking forward to this talk. So over to you.
Thank you very much. So I'm going to talk to you about our study, which evaluated a transdiagnostic mindfulness-based cognitive therapy group for service users transitioning out of secondary care. So the rationale for this study came about because from two sort of related bodies of research, so CBT literature, which is increasingly sort of focused on contextual approaches, and including MBCT, which is shown to be effective across a range of diagnoses. And in transdiagnostic literature, MBCT is thought to target transdiagnostic cognitive and behavioural processes and core processes of experiential avoidance, control, and inflexible awareness. Despite this, there are no studies that explore the therapeutic and theoretical potential of MBCT within a single study or in a real-world clinical setting where service users often have mixed and multiple diagnoses, or where diagnosis may change over time. So the aims of the study were to evaluate the usefulness of group MBCT for a transdiagnostic population of service users within an enhanced primary care team. A second aim was to investigate the impact of group MBCT on a wide range of cognitive and behavioural processes, including the 3 proposed core processes, so that's experiential avoidance, control, and inflexible awareness, and also to look at changes on symptom-based and goal-based outcomes. And finally, to explore the experience of therapeutic change within the group. So a mixed methods design was used, and we wanted to be inclusive and not screen out people. So participants had a range of diagnoses and presenting problems. And interestingly, presenting problems didn't always match up with the diagnoses that they received. So participants attended the 8-week group, which was facilitated by an experienced facilitator. And they completed measures weekly and at 1-month follow-up. So I'll just briefly show you this slide. I won't go through everything, but these are the measures that we kind of considered. Symptom-based measures were tailored to kind of participants presenting problems, and we used process-based measures, and we spent a lot of time sort of considering the questions to use on a goal-based outcome as well. After the final group session, 5 participants also attended a follow-up interview. And the findings are as follows. So visual analysis suggested that group MBCT helped participants move towards valued goals, and increases ranged from 1 to 6 points at week 8 and from 1 to 7 points at follow-up. It also decreased engagement in cognitive and behavioural processes, with reductions of between 13 and 46 points at week 8 and between 60 and 50 points at follow-up. We also found that increased inflexible awareness, with increases ranging between 3 and 17 points at week 8 and 1 and 20 points at follow-up. So in all these cases, the changes at follow-up were greater than at week 8. And finally, we also noticed an increase on the reorganisation of conflict scale, with increases relating between approximately 3 and 27 points at week 8 and between 6 and 25 points at follow-up. There seemed to be an inverse relationship between the cognitive behavioural processes questionnaire and the reorganisation of conflict questionnaire. So we noticed that as scores on the CBPQ decreased, scores on the ROC increased. So this suggests that as reorganisation of conflict occurred, people engaged less in cognitive and behavioural processes that are associated with distress. And our next steps are to kind of look at whether these changes are statistically significant. Interestingly, no changes were observed on symptom-based measures or the measure of experiential avoidance. In terms of the thematic data, so participants described this change as becoming unbound from distress, not feeling stuck, for example, in patterns of behaviour, and not spiralling out of control. They also spoke about taking back control, so by managing better in the moment, having a new outlook and seeing new possibilities, and seeing change as a journey that's not necessarily linear. So in conclusion, we can say that MBCT seems to have potential as a transdiagnostic intervention in clinical settings where there's high levels of heterogeneity and comorbidity. Findings from visual analysis, just to say that actually delivery in a group format has kind of pragmatic implications in that it can kind of reach more people and have kind of a clinical use, for example, when people are on a waiting list for individual therapy. MBCT had the predicted impact on cognitive behavioural processes and core processes, except for experiential avoidance. And this is interesting because experiential avoidance has been sort of championed as a core process underlying distress, but we didn't really see much change on this measure. So findings from the visual analysis, particularly the observed relationship between the CBPQ and the ROC, suggest that control may be a core process underlying distress, which is supported by participants' descriptions of change within the group. And these findings raise interesting questions about the over-reliance on symptom-based measures of distress and how useful these are as outcome tools. But just to end with some kind of food for thought, if we didn't have any of the boundaries that we usually have as a service, it would be interesting to think about what the implications of these findings would be. Thank you, that was a lot.
What a lovely synopsis of that study. Thank you. I know these 5-minute talks aren't very easy, so much appreciated, Louise. Big round of applause for you. And if you don't mind stopping sharing your screen, I'll ask our next speaker to share her screen and so we can see her slides. And I'm delighted to introduce Dr. Amanda Mount from Hertfordshire Partnership NHS. Gosh, I can't speak now, can I? Hertfordshire Partnership NHS Foundation Trust. There we go. It's a mouthful. Welcome, Amanda.
Thank you. Can you just tell me how I share my slides? Because I can still see Louise's.
All right. So if Louise is on the bottom, Louise, if you put your mouse over it, it should say stop share. So I don't have control, Warren. I don't know if you, oh, brilliant. Okay, and now you should be able to press share screen, Amanda, and hopefully that will be good.
And can you see my notes or my actual presentation?
We can see your notes as well, rather than just the presentation. But if that's the problem, don't, if you're all right with that, don't worry too much.
Sorry, technical.
If you click on slide, oh, this slide. Sure.
Yeah, I don't know if...
Yeah, right from beginning.
Can you see it now?
Click that button that you're on now, and that's it.
Oh, brilliant. Okay. So myself and Dr. Patel have provided a brief summary of our research. Mechanisms of change of therapy remain poorly understood, despite there being extensive research in the area, and studies have mainly used quantitative methodologies, even though clients have been recognized as a site of change and contribute to change process more than any other factor. Their views are scarcely researched and therefore the literature is skewed. So our study addressed the above gaps in addition to the recommendations of the 3 studies mentioned here, as well as continued consultation with an expert by experience service user group throughout the research. The study therefore aimed to explore clients' perspectives and understanding of change in therapy. The 2 research questions were: how do clients define change in therapy, and how do clients describe their experience of psychological change in therapy? The sample comprised of 10 participants, 3 males, 7 females, aged 20 to 59 with varied ethnicities. Participants self-reported experiencing positive change through CBT in a secondary care NHS mental health service, and they reported varied and multiple psychiatric diagnoses, and no distinction was made between categories of mental health difficulties. Data was collected through individual in-depth face-to-face semi-structured interviews lasting between 60 and 90 minutes. 3 themes were identified using thematic analysis: change is changeable, allies along the way, and no magic wand. Change is changeable have 3 sub-themes: the roller coaster of change, which highlights the dynamic up and down process of change. Change leads to change, which is that change propels and promotes further change, and changing expectations, that the expectations and what changes itself varies over the course of therapy. Within the theme of allies along the way, participants identified that therapists had a key role in change in therapy, and other sub-theme highlighted that there was help beyond therapy. Religious leaders, charity support workers, family and friends were important. The final theme, no magic wand, encapsulates the role of the client and the active role they need to take to achieve change. The sub-themes found illustrates the importance of realization and motivation for change, participants taking control, and that they want to escape negative feelings and pushing through the difficulty of change despite the challenges they face. The findings revealed that although some specific factors of CBT were mentioned, participants placed emphasis on the common factors of therapy, such as therapeutic alliance and gaining awareness and control as needed for change. Participants also described attention, perspective, awareness processes, which map onto common core processes and are aligned with contextual transdiagnostic approaches such as mindfulness and method of level therapy. Although some of the findings, such as non-linearity, can be explained by other theories such as TTM model of change, perceptual control theory integrates and offers the closest match of theoretical explanations. For example, the up and down process can be thought of as the trial and error process to reduce conflict and realize goals. Light bulb moments can be understood as process of reorganization linked to awareness. Clients being in control and having an active role in change links to PCT control hierarchy, which suggests that when clients have control over when and where and what they talk about in therapy, they're likely to move up the hierarchy. Changing goals across therapy is akin to the changing preferred states. So what was important to the client at the start of therapy may no longer be as reorganization is happening. Although participants reflected difficulties in articulating that understanding of change, they were able to identify the aspects that make up change, and the outcome of this research is that participants have offered a working definition of change. Participants defined change as something that was moving in the wished for direction, and largely change was referred to as meaningful if it made a difference to the person, which differs from Evan's previous research that participants didn't refer to the worth of change to society or societal values. Instead, they focused on their feelings and personal satisfaction with the change. And furthermore, the end of therapy didn't mark a final point in the change journey. It was considered a stage at which participants were able to continue their change journey without the guidance of therapists. The study of finding highlights the complexity of the change process in therapy and emphasizes the importance of clients' perspective within this. At an individual level, participants indicated that remittance of symptoms shouldn't be the primary focus of mental health support, and that finding meaningful change for individuals may be more valuable, for example, being able to engage in other activities. It's important to revisit goals throughout the process and furthermore talk to clients about how therapy works and engage them in the dialogue about what change means to them throughout therapy. To do so, the researcher recommends listening further to clients' viewpoints, additionally normalizing the up and down process of change and helping to set expectations in therapy. At wider levels, the implications are in the measuring of change and commissioning services in light of the non-linear process of change. Review of what therapies are offered and the focus of change is important. Additionally, restructuring the use of diagnostic categories in offering support in services is indicated. Furthermore, linking services with organizations and charities would be helpful to support individuals' change journeys. And finally, at the research level, it would be valuable to continue further research to include service user perspectives, reviewing the literature to consider whether similar constructs of change are being considered based on the working understanding of change service users have offered. And lastly, to develop individualized outcome measures that capture meaningful change. Thank you for your time and for the organisers today for the thought-provoking conference.
Thank you, Amanda. Round of applause. I've got to say, I'm absolutely loving the 5 minutes talks. They're like little gems, aren't they, in this conference? So much that we get from them, even though they're so short. So that brings us to the end of all of our planned sessions of talks. And we've now got around 30 minutes of discussion, and we've entitled this discussion session, "What are the ways forward, for transdiagnostic research and practice as well?" But of course, we can also use this time to go back to any of the talks, discuss the things that came out of those. Totally over to you. Did you want to make any comments, Warren, as well?
Oh, it's been a whirlwind, hasn't it, for 2 days? Bringing everyone together across the world to share these ideas, and kind of we've been moving territory within our shared interests, haven't we, in terms of cognitive behavioral processes, in terms of network analysis, brain systems, and now more of a kind of control-oriented approach. Yeah, there's some kind of practical questions about what we call this conference going forward and how we truly kind of do justice to the wide range of approaches here. And then there's more kind of strategic ones, aren't there, really, about how we make this work known. I mean, there's so many decisive comments made around particularly Aiko and Tim's talks today, but also building on yesterday's, that arguably the kind of the facts of history and the kind of the nature of the science in terms of the methodology and the theory and people's lived experience should really be all pointing towards a transdiagnostic or an adiagnostic or a universal approach. And so it rests on us to think about what the next steps are with this, besides obviously disseminating this, the conference itself, thinking about where to do it next time.
Well, it'd be good to hear all sorts of opinions. I'm just checking. Do we want to still keep recording, or do we want to stop recording so people might be a bit more?
Yeah, let's stop. Let's stop. So